Megaloblastic anemia is a disorder of impaired DNA synthesis. It occurs when a hematopoietic stem cell has the necessary protein building blocks to grow, but lacks the specific cofactors required to replicate its genetic material. This creates a mechanical failure known as nuclear cytoplasmic dissociation. The cytoplasm matures, absorbing nutrients and expanding its volume, while the nucleus remains structurally immature and entirely unable to divide. Because the cell cannot undergo normal division to reduce its size, it enters the bloodstream as an oversized, defective red blood cell. On a complete blood count, this cellular arrest directly drives the mean corpuscular volume, or MCV, well above the standard 100 femtoliters. This high-resolution peripheral blood smear illustrates the first half of the condition's pathognomonic triad, the presence of large, distinctly oval-shaped macrocytes, easily distinguishable from the normal-sized red blood cell adjacent to it. The stalled DNA synthesis also affects the myeloid lineage, creating the second half of the pathognomonic smear, the hypersegmented neutrophil. There are strict criteria for identifying hypersegmentation. You must observe either a single neutrophil containing 5 or more lobes, or find that at least 5% of the neutrophils on the slide possess exactly 5 lobes. Encountering oval macrocytes alongside hypersegmented neutrophils narrows your diagnostic differential immediately. It confirms impaired DNA synthesis and requires an immediate pivot to investigate vitamin B12 deficiency, folate deficiency, or direct drug-induced etiologies. Not all large red blood cells indicate a failure of DNA synthesis. Non-megaloblastic macrocytosis operates through entirely different mechanisms. This morphological comparison shows the distinction. Megaloblastic cells on the left are oval and accompanied by hypersegmented neutrophils. By contrast, non-megaloblastic causes, such as chronic liver disease or heavy alcohol use, produce the cells on the right, perfectly round macrocytes that frequently take on a target cell appearance with entirely normal neutrophils. As a clinical rule of thumb, etiologies like liver disease and hypothyroidism rarely push the MCV past 114 femtoliters. An MCV climbing higher than 130 femtoliters is highly specific. At that volume, the differential effectively shrinks to megaloblastic anemia or a direct pharmacological effect. The third classic laboratory finding in megaloblastic anemia involves a profound elevation in lactate dehydrogenase, or LDH, accompanied by elevated indirect bilirubin. This anomaly stems from ineffective erythropoiesis. The arrested, oversized precursor cells are highly fragile, and the bone marrow frequently destroys them internally before they ever have the chance to enter the peripheral bloodstream. This creates a dangerous diagnostic trap. The combination of high LDH, high indirect bilirubin, and low hemoglobin frequently misleads clinicians into diagnosing a consumptive intravascular hemolytic anemia. The true pathology is bone marrow failure triggered by arrested DNA synthesis. Vitamin B12, or cobalamin, and folate are biochemically linked. Both function as essential cofactors in the complex synthesis of DNA precursors. This flowchart illustrates their shared metabolic sequence. Both vitamins are required to convert homocysteine into methionine. If either is deficient, the pathway halts entirely. As a result, serum homocysteine levels rise identically in both B12 and folate deficiencies. Because homocysteine accumulates in both scenarios, testing for it is highly sensitive for a defect in DNA synthesis, but nonspecific for differentiating between the two vitamins. The critical metabolic divergence occurs in the methylmalonic acid, or MMA, pathway. The conversion of MMA into succinyl-CoA relies exclusively on vitamin B12. Folate is not involved, so a pure folate deficiency has no effect on MMA levels. This establishes a definitive diagnostic rule. An elevated MMA confirms a B12 deficiency. A normal MMA, coupled with an elevated homocysteine, confirms an isolated folate deficiency. Relying solely on a standard serum B12 level is risky. Serum measurements can be falsely normalized by concurrent liver disease or myeloproliferative neoplasms. When confronted with a megaloblastic smear, checking MMA and homocysteine levels is the only biochemically foolproof method to separate the two deficiencies. B12 absorption is a complex, multi-stage journey. It begins in the stomach, where B12 must be cleaved from ingested food proteins by gastric acid. Chronic use of proton pump inhibitors or H2 blockers suppresses this acid production. Without initial cleavage, B12 remains bound to food protein and passes unabsorbed. Once freed, the B12 must bind to intrinsic factor, a transport protein produced by the gastric parietal cells. Pernicious anemia is the autoimmune destruction of these parietal cells. It is the most common cause of B12 deficiency in Western countries, and testing for anti-intrinsic factor antibodies provides a highly specific diagnosis. The B12 intrinsic factor complex travels the length of the small intestine to the terminal ileum, the only site where it is absorbed into the bloodstream. Iatrogenic disruptions frequently occur at the ileum. Long-term use of metformin directly impairs ileal absorption of this complex, requiring annual B12 screening. There are also biological competitors that intercept and consume B12 before it reaches the ileum, including bacterial overgrowth and the fish tapeworm. The human liver stores enough B12 to last for 3 to 5 years. Clinical B12 deficiency almost always represents a long-term chronic failure of absorption. The lone acute exception is exposure to nitrous oxide gas, which instantly and irreversibly inactivates the body's existing B12 stores. By contrast, the body holds only a 3 to 4 month supply of folate. This minimal reserve makes patients highly susceptible to acute dietary deficits. The primary drivers of folate deficiency are pure dietary lack, classically seen in chronic alcoholism or elderly populations, and malabsorption states like celiac disease. Increased physiological demand can rapidly drain these limited stores. During pregnancy or in the setting of chronic hemolytic anemias, folate is depleted quickly. When testing, an RBC folate test is a far more accurate reflection of true tissue stores. Serum folate simply fluctuates based on recent meals. Megaloblastic changes can also be completely independent of vitamin levels. Certain medications directly interfere with DNA synthesis, yielding identical peripheral smears without underlying deficiency. The high-yield pharmacological culprits include hydroxyurea, 5-fluorouracil, azathioprine, phenytoin, trimethoprim, and methotrexate. Methotrexate acts as a direct potent folate antagonist. Megaloblastic changes triggered by it cannot be overcome with standard folic acid. They require targeted leucovorin rescue. Clinically, there is an absolute dividing line between these two deficiencies. B12 deficiency causes severe neurological disease. Folate does not. This spinal cord cross-section maps the specific neurological syndrome caused by B12 deficiency, subacute combined degeneration. The demyelination of the dorsal columns at the posterior of the cord results in a progressive loss of vibration sense and proprioception, culminating in sensory ataxia. Simultaneously, demyelination of the lateral corticospinal tracts along the sides produces compounding motor symptoms, including symptoms of progressive weakness, spasticity, and hyperreflexia. Irreversible neurological damage from B12 deficiency can occur entirely without the presence of macrocytic anemia. Waiting for a patient's hemoglobin to drop or their MCV to rise before working up unexplained paresthesias or ataxia will result in missed diagnoses and permanent nerve damage. This brings us to the folate trap, one of the highest stakes errors in hematology. It occurs when a clinician reflexively prescribes folic acid for an undifferentiated megaloblastic anemia. In this split-screen visualization, flooding the system with folate bypasses the DNA synthesis bottleneck. The CBC normalizes, macrocytes disappear, and the anemia resolves. But because folate cannot fix the B12-dependent pathway, toxic metabolites continue to destroy the nervous system. The clinician has successfully masked the hematological warning signs while allowing irreversible spinal cord demyelination to progress completely unabated. Never administer therapeutic folate to a patient with macrocytic anemia until a B12 deficiency has been definitively ruled out via serum B12 and MMA testing.